Good evening. This is John Miller from Indiana University School of Medicine with a webinar on practical aspects of rotor mapping in catheter ablation of atrial fibrillation. We have several objectives this evening. First of all is to provide background on rotor mapping in atrial fibrillation ablation procedures, review some current experience with rotor mapping in these procedures, describe workflows for the most efficient use of this technology and strategy during mapping of atrial fibrillation and ablation, and we'll review some rotor maps and strategies used during several different procedures to get an idea of how this all works. Finally, we'll suggest reasons for differences in outcomes from some users of rotor mapping and ablation that are existing in the literature today. By way of background, it's clear that multiple mechanisms may be operative during all different types of atrial fibrillation, whether paroxysmal, persistent, or long-standing persistent in man. Certainly, the pulmonary veins are important. There's no disputing this. They may act as drivers that maintain atrial fibrillation for as long as the driver is active, and when the driver stops, the atrial fibrillation stops. Pulmonary veins can certainly also act as triggers that initiate atrial fibrillation but are not needed to continue firing for its ongoing perpetuation. Also, non-pulmonary vein triggers exist. This much is quite clear from the literature and experience. Multiple wavelet reentry may maintain AF even when other mechanisms have finished. And finally, rotors may maintain AF. There's abundant literature that this is a prominent feature of atrial fibrillation in man as well as animal models. In atrial fibrillation, we have pulmonary veins firing. We see these PV potentials that we all recognize, a left atrial potential, then a pulmonary vein potential during sinus rhythm beats. Spontaneous firing from the pulmonary vein initiating a short episode of atrial fibrillation that then stops and goes back to sinus rhythm. And after ablation, the pulmonary vein potential is gone. We're all familiar with this, and we're all familiar with situations such as this, in which we have atrial fibrillation continuing on in an isolated vein segment while sinus rhythm is present in the rest of the atrium. In our experience, this is quite uncommon. This is a clear driver that is present, and as long as it is connected to the atrium, fibrillation is seen in the atrium, and when it's disconnected, fibrillation desists in the atrium while it perpetuates in the vein. However, it's clear also that while pulmonary vein isolation is foundational in most current atrial fibrillation procedures, it's not the uniform and comprehensive answer. Our objective results are not quite as good as we think. Everyone has in their mind this 70% success rate in paroxysmal atrial fibrillation, but objectively, it's just not that good when you're looking for hard endpoints and outcomes. We also see that despite complete isolation of pulmonary veins during a procedure, atrial fibrillation may continue. How are the veins causing atrial fibrillation then? Sometimes when we have atrial fibrillation terminating during ablation, we almost never see that the pulmonary veins are isolated under those circumstances. So again, how can they be causing atrial fibrillation to persist under those circumstances? When we do repeat procedures on people who have had a prior pulmonary vein isolation procedure, we quite often will see that the veins are already isolated. How are the veins causing atrial fibrillation under those circumstances? So additional strategies besides just pulmonary vein isolation are necessary in many cases. So what we're all going to do? If that's not the entire solution, then people have applied empiric lines on the left atrial roof, the mitral or tricuspid isthmus, the superior vena cava, coronary sinus may be isolated, going after complex fractionated atrial electrograms. It's been in favor, out of favor, back in favor, back out of favor. Looking for non-pulmonary vein triggers to isolate on high-dose isoproterenol or epinephrine at the end of a procedure. Posterior wall isolation, left atrial appendage isolation, scar mapping and ablation and homogenization, and finally, rotor mapping and ablation have all been used. We'll talk about rotors for the rest of our time here this evening. So back in 2005, Sanjeev Narayan, then at University of California, San Diego, used multiple recordings from basket catheters in the left and right atrium and a special analytical algorithm which he derived showing that there were these rotors in each atrium operating sometimes independently. These were sites of complete rotation that were stable over several cycles for as long as he could record them. With some degree of precession within a small area, these rotors would move around like a child's top on a glass tabletop, spinning away. These were in relatively small circumscribed areas. He found that multiple rotors may be operative at the same time, either in the same or in the opposite atrium, and sometimes playing off each other which would give rise to very complex interactive patterns with fibrillatory conduction. Occasionally, focal sources were seen of spontaneous firing instead of rotor patterns. These were not quite as common. In the pivotal study that he reported some years ago, comprising 92 patients with 107 procedures, he used focal impulse and rotor modulation, or FIRM, data that was acquired in all patients, and all patients had pulmonary vein isolation as well. There were two arms to this study, as we all recall. There was a FIRM guided arm in which the maps were used to actually guide where ablation was done, and in another arm, a larger portion of the series, data was collected from FIRM mapping, but ablation was performed based on pulmonary vein isolation only in those cases, and there was a retrospective analysis as to where the sites of rotation were. About 3/4 of these patients were persistent atrial fibrillation of the breast paroxysmal. FIRM-guided ablation was targeted on the center of rotation detected on the maps, such as we'll see. Ablation was continued until one of a couple of endpoints occurred, either atrial fibrillation terminated to sinus rhythm or an atrial tachycardia, or about 10 minutes of ablation had elapsed. He limited himself in that study to a maximum of 3 targets, which was adequate for his purposes at the time. FIRM ablation was performed as the original ablation in cases in which it was FIRM guided, and then pulmonary vein isolation was performed afterwards. That's an important difference from what we do nowadays in most cases, as we'll see. And monitoring afterwards for recurrence of atrial arrhythmias was as by HRS guidelines. And importantly, about 88% of patients in the FIRM guided group and about 1/4 of patients in the FIRM blinded group had implanted devices with an atrial recording, such that it was a very good objective recording of whether atrial fibrillation had occurred. The mean follow-up was a little under a year. With that, Dr. Narayan found that with FIRM and pulmonary vein isolation, the objective guideline directed freedom from atrial fibrillation was about 88% at 1 year of follow-up, whereas with pulmonary vein isolation alone, it was only about 45%, with a lesser number of implanted devices to detect atrial fibrillation. This is a dramatic difference, of course, and was quite well accepted at the time. However, there was pushback from reasoned skepticism in the atrial fibrillation ablation community. And although he was able to detect rotors in almost all patients, it doesn't mean that they necessarily have a role in maintaining atrial fibrillation. But what kind of evidence would indicate that they are responsible and have a significant role in atrial fibrillation? Well, if you ablated at these locations that then influence outcome in some way, that would indicate a mechanistic role. So one, for instance, might find that one might be able to terminate atrial fibrillation episodes when guided by FIRM mapping, and that if atrial fibrillation were easily inducible earlier in the procedure and cannot be induced afterwards, that might indicate that the site ablated as guided by rotor mapping had a role in maintenance of atrial fibrillation. And finally, if the individual did not have recurrent atrial fibrillation on long-term outcome based only on FIRM mapping, this would be strong evidence that FIRM-guided ablation actually had some merit. So here's a situation I want to tell you about. This is my 64th case that I had done. This is a 55-year-old man with 3 prior cardioversions that had only been translated successful. He came to the lab in sinus rhythm. We were easily able to induce atrial fibrillation with just a short burst of pacing from the coronary sinus. This is in the absence of isoproterenol. And the atrial fibrillation cycle length is relatively rapid here, relatively disorganized, very rapid wavefronts here. So we were able to get atrial fibrillation to sustain for 20, 25 minutes. It would terminate. Another burst of pacing would immediately get him back into this same arrhythmia. This is recordings from the basket catheter, 64 unipolar recordings shown up here. We'll go over this a little bit more detail in subsequent slides here. But I want to point out that our basket recordings are rather clean. There's a little bit of 60 cycle in the background, but they're pretty clean recordings and pretty organized, whereas the coronary sinus recordings are a little bit more disorganized. This is not an unusual situation in our experience. And of course, the surface ECG is quite clearly fibrillatory. This is the FIRM map in this individual here. This is in the left atrium. And we see a wide rotation going around counterclockwise, white followed by gray and black, white followed by gray and black in this counterclockwise rotation here. And we have the different splines of the basket on this axis and the different electrode numbers on the bottom axis here. The colored areas here are a thing called a rotational activity profile. This is an enhancement of what's going on in the software that tells a little bit more of where to focus our attention on. There's another feature here that blacks out the background here. It's called spotlight, and the extraneous information around the outside is kind of masked for us to be able to see a little bit more clearly what's going on. So in this individual, here's our atrial fibrillation at 160, 170 milliseconds in the coronary sinus recording at the very start of ablation. After about 2 minutes here, the atrial fibrillation changes to a more organized atrial flutter with cycling through around 190 milliseconds. And about a minute after that, atrial fibrillation terminates directly to sinus rhythm, as we can see here. Now, when we tried to reinitiate atrial fibrillation after doing a little bit more consolidative ablation in that region, we couldn't. And in fact, here's bursting at 160 milliseconds. This is as fast as my stimulator will go. This is now on 10 micrograms per minute of isoproterenol. You see a little bit of surface ECG noise from how jittery the patient is on this much isoproterenol, and he's in sinus tachycardia. And this is the most we could get out of him, a couple of beats, repetitive beats of atrial arrhythmia. So in this situation here, this 55-year-old man who's had persistent atrial fibrillation for 8 months or so, this is the area we ablated on the septal aspect of the left atrium. Left atrium shown in gray here, the right atrium in green with the phrenic nerve dots indicated pacing sites for the phrenic nerve in black here. Superior vena cava, inferior vena cava. So this is the septal or aortic aspect of the left atrium. It's a relatively dense ablation in this region. The purple spot is where the atrial fibrillation terminated. So in this gentleman, we felt that our site indicated by firm mapping was definitely related to the ongoing atrial fibrillation process because we had acute termination of atrial fibrillation when ablating. Guided by this, we eliminated the ability to initiate atrial fibrillation thereafter, even with stronger methods than were required baseline, and he's been free of atrial fibrillation on follow-up for over 16 months now. I would point out that this was a firm-only ablation. We did not do pulmonary vein isolation in this particular individual, and yet he's remained atrial fibrillation free. A little bit about process here. These are baskets that have been used. We don't use the Constellation catheter anymore. I show it for reference up here. It's easy to see on fluoroscopy. The electrodes are quite large and circumferential around the splines of the basket catheter. This is deployment in the right atrium, in the right anterior oblique and left anterior oblique in the left atrium in both cases here. You see on the Constellation catheter that the splines are really front-loaded towards the tip of the catheter and the splines. We don't have any representation of recording electrodes back here on the proximal end of the basket, which of course is quite a problem for looking at septal aspect of the left atrium. On the FirmMap catheter that's now used, we have electrodes that are printed on the outer surface, so much less likely to get catheter bang artifact when maneuvering an ablation catheter on the inner aspect of the FirmMap catheter. You see also that electrodes go all the way back. You don't see the most proximal one here, but they're evenly distributed along the splines here. The splines tend to splay out when the basket is deployed in the atrium in a much more uniform manner than the Constellation catheter did. The splines tended to bunch together, and it took a fair amount of work to get them to distribute nicely. So I show the fluoroscopic recordings of the Constellation catheter here in two views. The FirmMap catheter, the electrodes are much more difficult to see. I have to draw a red circle around where the basket really is deployed in the left atrium. It's just very difficult to see these. This is a FirmMap catheter in one of our procedures in the right atrium and the left atrium, right and left anterior oblique recordings. And again, I have to illustrate where these the boundaries of the basket catheter are. They're just really difficult to see. But I think you can see that in this case, it's coming kind of straight out at us here in the left anterior oblique and the right atrium. You can see these splines are rather well distributed here, evenly distributed. And then the right atrium, you can see in the left atrium. Again, looking down the barrel of the basket, the splines are relatively uniformly distributed in the left atrium with pretty good coverage. With that, we get these recordings. These are all 64 unipolar basket recordings. There's a large ventricular recording here that's subtracted out by the software. But again, these are relatively clean unipolar recordings in this situation, quite disorganized during atrial fibrillation, and the coronary sinus recordings in the middle here. We record for a minute of atrial fibrillation with all 64 unipolar recordings at a kilohertz sampling frequency with standard unipolar filtering settings. Now, in the initial studies with firm-guided mapping and ablation that Dr. Narayan did and with which we participated as well, these were a proof of concept. So we did firm ablation first. We wanted to see what the effect of ablation was guided by firm mapping in these cases without the influence of pulmonary vein isolation. That was important as proof of concept. We also started in the right atrium and then went to the left atrium. There was no necessary reason for that. That's just the way things initially went. We wanted to make sure we were not missing out on right atrial sources that have turned up in a fair number of cases. The turnaround time for mapping was about 25 or 30 minutes. We had to record the minute of atrial fibrillation, send it over the internet to San Diego for analysis, and then get the movies back. The analysis was quite prolonged. And about 25, 30 minutes later, we'd have a map to see on our machine. We could then direct our ablation catheter to that area and ablate, and then we could remap. But obviously, with this type of turnaround time, we couldn't do more than 2 or 3 maps per procedure. The endpoints then had to be based on something we could see right then and there. So if we terminated atrial fibrillation, either the sinus rhythm or an atrial flutter or tachycardia, or the atrial fibrillation cycling slowed by 10-15%, we could measure these outcomes. But we obviously didn't have any way of looking at long-term outcome, or even as to whether we had eliminated the source because of this long turnaround time. As firm gained experience and the software improved, the workflow has changed somewhat. Many sites are now using firm for a subsidiary role, and finding that since many of the sites directed by firm mapping were within what would be a standard wide area catheter ablation or WACA line, some investigators have said, well, if we're going to be knocking off those areas anyway with a WACA line, let's go ahead and do the wide area catheter ablation, do our pulmonary vein isolation first, and anything that's left over we'll do for firm mapping. So the strategy has changed in many laboratories to doing pulmonary vein isolation first. It's a little bit more efficient that way, since you get a twofer, gets rid of some sources of atrial fibrillation and rotors in the process of doing the pulmonary vein isolation. Many of us also found that when we did the firm maps before and after pulmonary vein isolation in the same individual, the signals were a little bit cleaner, less contamination of the pulmonary vein potentials, and a little bit easier to read these maps. I think that's probably true in most experience nowadays. So that's another advantage to starting with pulmonary vein isolation. Nowadays, we start with mapping firm sources in the left atrium and then go back to the right atrium. It doesn't have to be that way. It's just the way things have settled out in many laboratories. And now our endpoints are, importantly, the elimination of the source, because our turnaround time is much more rapid. We can do the map, we can do the ablation, and then remap right away and get an answer within just a few minutes. Have we eliminated that source? That's a much better and harder endpoint in most of our experience nowadays. So the way this works in my laboratory, this is obviously not the only way to do it, but it works for me. We get femoral vein access on both sides. I put in the right femoral vein. We get a couple of catheters into the left atrium after transeptal catheterization, and I have a separate short sheath for separate right atrial mapping instead of moving the catheter back and forth in and out of the left atrium through the sheath. I just leave a sheath over there if I'm going to be mapping in the right atrium. I have a coronary sinus catheter and a His catheter in the left femoral vein, and a short sheath either for ICE catheter, a halo catheter if I need it, or deploying a long sheath for right atrial basket, which we usually do in these cases as well. Once femoral vein access, and I usually use a short catheter for an artery as well for online blood pressure monitoring, we go ahead and anticoagulate, then proceed to transeptal catheterization. get the right atrial anatomy and tag where the phrenic nerve is, or being able to avoid that area with firm guided mapping in the right atrium. Go over to the left atrium, again, get a fast anatomic map of the left atrium with the biosynth system that we use, tag the esophageal location, and then go ahead with mapping and ablation, which we see on the next slide. If the individual is in sinus rhythm at the time, we'll go ahead with pulmonary vein isolation, and thereafter attempt atrial fibrillation ablation. If we can't get any, the procedure is pretty fast. We're done with it, despite epinephrine use, which is what we use nowadays instead of isoprostol for cost. If we get atrial flutter or atrial tachycardia, we'll go ahead and map and ablate those, and then reattempt to initiate atrial fibrillation iteratively until we get either nothing or get atrial fibrillation. If we get atrial fib, we go with firm mapping. We'll see that subsequently. If the individual starts in atrial fibrillation, we'll go ahead again with pulmonary vein isolation. And if atrial fibrillation terminates, we'll try to reinitiate it and go around this loop again. If we terminate, atrial fibrillation does not terminate despite pulmonary vein isolation, we'll proceed with firm mapping. If our initial rhythm is atrial tachycardia or flutter, we can do either one of these strategies here, do the pulmonary vein isolation or ablate the atrial tachycardia or flutter, and then proceed down this algorithm. Once we start with firm mapping, I start, as most of us do, in the left atrium. If we see a source with firm mapping, we will plot its region on the electroanatomic map. I'll show you how we do that. There are a couple of ways of doing that. Ablate that region rather liberally. If atrial fibrillation persists, we go back up and remap. If the source is still seen, we just keep going around until we eliminate the source, or in which case we have no source seen. We will then move the basket around to make sure we have adequate coverage of all areas of the atrium and remap. If we see a new source with that, we'll go ahead and replot it on the electroanatomic map, ablate that region, and keep going around. If we are done seeing sources in the left atrium, we go to right atrial firm mapping and ablation. Now back over here, if when we are ablating that region, we stop atrial fibrillation, either to sinus rhythm or atrial tachycardia or flutter, we will map the flutter and so forth. And then once it terminates, attempt atrial fibrillation reinitiation again, as we saw on the previous slide, and just keep on going around until we eliminate the source, or we have eliminated atrial fibrillation, eliminated atrial flutter, we get to sinus rhythm and can't initiate atrial fibrillation anymore. If we've eliminated all possible sources and in both atria and the patient's still in fibrillation, we will then cardiovert and see if we can find triggers for atrial fibrillation reinitiation or tachycardias, flutters, and so forth. So it's a somewhat involved process. The bottom line that we're trying to do is eliminate our rotors and foci on repeat mapping. Simple termination of the arrhythmia we've not found as a reliable indicator of elimination of the source. Now, some important aspects of this. It is very important to get a good position of the basket in the atrium. We find that if you can get it sized well, and this is typically the distance between the septum and the carina of the left pulmonary veins, if you can get it sized well for the left atrium, it fits well there. It'll also fit in the right atrium. That's almost always the case. The basket comes in 50, 60, and 70 millimeter lengths from proximal to distal portion, and most atria, we've not found situations in which we have picked the wrong basket size just yet. I suppose that's possible. For optimal deployment, we need to make sure that once you get all the splines deployed, for instance, in the left atrium, we give the catheter a little bit of a twist. It helps separate the splines. They tend to separate out pretty nicely on their own, but sometimes, especially if it's a relatively tight fit, you have to give a little bit of a twist on it and move the catheter in and out to get the splines to separate nicely and make good contact. It's important to have a good grounding electrode. We use a separate patch on the opposite thigh from where the ablation grounding pad is. Others have used an electrode on an indifferent catheter within the circulation to do this. It doesn't really matter which. We record a minute of unipolar basket electrograms and then export that minute as a text file to a USB and walk it at 10 feet across the room into the Rhythm View a computer system. The algorithm automatically selects a 4-second segment that has the best quality data. It's not the segment with the best pictures, it's the segment with the best data content, and usually gives us a second segment that we can look at that has not quite as good data, not quite as clean data, but good data nonetheless. And it takes about a minute or so for this analysis to go forward. Then the movie is viewed on the screen. I like to view it just as it is, as a raw movie, and see if I can see any sources that's either rotors or foci flashing of activation. We'll see some examples of this. And I try to gauge not only where it is, but how confident I am that, yes, we're seeing a repetitive source, how many turns it has, is it precessing very much, or is it staying pretty static? Then we apply some visual aids, the RAP or rotational activity profile. I showed that a little bit earlier. We'll see some of that later. It highlights areas where the machine has said there's a high degree of confidence that we have rotation in this area. It's highly repetitive. If the machine's pick agrees with what I see, then we usually confirm that with a second segment that the machine has picked for us to look at. I might pick another random segment from that minute, and then we proceed with our mapping and ablation. Here's an example of a rotor in the right atrium, and we have this rotation going around in this direction over here. The RAP, the rotational activity, highlights this, and we can see it going around pretty clearly here. The spotlight feature that come on in a second here also indicates that. Here's the RAP area here. The spotlight shows that up, kind of masking stuff that is extraneous. But we see this rotating around in the right atrium there. Here's an example of a little more difficult case in the left atrium. And you might say, well, there's something going up here, but then it disappears. And so what I do is I play this a couple of times through, and I focus on one area and see if that is consistent. If it's not, then I move my eyes to another area and keep looking at that. But let's look here, for instance. There's an area here where there seems to be a clockwise propagation going around this way. Another area up here that's not quite as strong. But again, with the spotlight, it's a little bit more clear what's going on in this region here. So these features draw our attention to areas that might not be so well seen otherwise. There may be complex patterns that occur. I'm going to show you this case in the right atrium, where we have a rotation going around in this counterclockwise direction here, very clear, but a rotation in this clockwise direction, almost like looks like a fountain coming out over here. Now, in this situation, we have our splines down here, A through H, and our electrodes 1 through 4. And we would be looking at an area on splines B, C, and electrodes 2 through 4, for instances, where rotation is occurring. And we saw the RAP on this slide here. I'm going to show that again with this fountain coming up. Here's a secondary one over here that would be at approximately GH, splines G and H, and electrodes 3 and 4. So we would center our ablation on these areas. And again, the rotational activity profile will show us these areas here and here, and we would act on both of those areas in this particular case. Once ablation has been performed, we remap and see what we see. And this is hopefully what we'll see. This is in this same case that I just showed you. There's not a lot going on here of any organized nature. Certainly the areas that was rotating around in this way and rotating around in this way, they're just not evident anymore. And in fact, I've turned on the rotational activity profile. The machine doesn't see anything. There's no rotation left here. So we've eliminated the rotors in this situation. Here's a case in which we had a focus firing in the right atrium, and you can see it starting right here where the pointer is. It starts off as a kind of black area, and then all of a sudden this white area shows up. So this is a focus in the right atrium, seen in about 10 to 20% of our cases here. There's no actual rotation here, so if I turn on the RAP feature, it's not going to see anything. The spotlight's not going to see very much with this either. We targeted this area for ablation in this woman, and she's had an excellent outcome from this. So that we had a focus right there. Now, once we've identified the sources on our rhythm view mapping system, I get the coordinates as I showed, which spline it is, which electrodes are involved here, and focus on the core of rotation. There are a couple of ways of doing this. One can display only the 4 electrodes of the 2 involved splines, and this is by unpinning and repinning into a different pin box in the actual laboratory. I prefer this. It focuses me on exactly where I need to be. Other co-workers that I have or other workers in the field display all the electrodes, all 64 electrodes on the basket on the electroanatomic mapping system. I find this a lot to look at. I get easily distracted by this stuff. So I like to focus on just the electrodes we're looking at. I'll show you how we pick these. I then look at 2 electroanatomic mapping views, one looking down on the splines directly, and one looking at them in profile. This gives me an idea of exactly where I need to put my ablation catheter. And then when we start ablating, I try to get pretty dense ablation of the source area as we found it on the map, with a little surrounding area. This is the core, where the action is really most evident. That's where the rotational activity profile is highlighting. Has slight margin around there to allow for any area where the rotor might precess around in a small area or domain. The end point of this, again, is to eliminate near field recordings in the target area so as to eliminate the source on remapping. The area ablated is usually from 1 to 8 centimeters squared, and it requires 1 minute, 8-10 minutes of ablation to get to this endpoint of knocking down the signals so there are only far field signals left. Once we've done this, we remap with the firm map in exactly the same location and with the same electrode locations, and see if we have eliminated the source. If the source remains, which in my experience most recently is rather rare with our mappings and ablation strategy, I go back and check for residual electrograms and or slightly enlarge the area. Sometimes there might be trabeculations, especially in the right atrium, that we just miss and have to go back and hit those areas. This is a right atrial electroanatomic shell made by the Biosyn system, and you see here the entire basket, all 8 splines, all 64 electrodes are displayed. Reasonably uniform electrode and spline distribution in the right atrium here. But this is a lot to look at, and if you're trying to pick out a specific electrode, it just gets a little bit noisy. So what I like to do instead is have the 4 electrodes on the 2 splines that are involved. So for instance, in this case, it might have been splines G and H and electrodes 3, 4, 5, and 6, and so we pin those out as electrode 1, 2, 3, 4. It's what plugged into the mapping system, and so then I know exactly where I want to ablate. I'm looking down on the electrodes here, down on the splines, and then in another orthogonal view, I'm looking at the splines in profile, so I know where to put my catheter. This is relatively dense ablation in this area. You see the pulmonary vein isolation lesions here, as well as another rotor a little bit lower on the septal aspect of the left atrium, and the coronary sinus catheter over here. This is a view of the right atrium, a similar situation. You can just see the 2 splines involved here and the 4 electrodes that we've chosen. These indicate where the core of the rotor was in the lateral right atrium, kind of at the base of the appendage here. Again, rather dense ablation, looking down on the splines involved, and then this is looking down the barrel of the superior vena cava with the splines in profile here. You can just see the lesions on the right atrium here. The black dots here indicate the location of the phrenic nerve that we mapped previously. When we're in the midst of the procedure and doing our mapping, how do we assess the results? The initial work in firm mapping used either termination of the arrhythmia to flutter or even sinus rhythm in many cases, or cycling slowing as the endpoints. Because of the very long turnaround time, we had to have some way of saying whether we've done something or not. We couldn't reliably use elimination of the source because of this 25-30 minute turnaround time. But since 2014 or so, our on-site processing speed has shortened the process, so we can acquire a minute of atrial fibrillation and about a minute or so of analysis and see whether we've eliminated the source. This has sped up the procedure substantially as far as getting our answer, but it makes us able to now take more maps. So the net time taken during mapping and ablation of rotors is about the same as it was. We usually attempt to reinitiate atrial fibrillation if it stops as a result of firm ablation. That's a standard stimulation protocol, 1 or 2 extra stimuli, 1 or 2 sites of ablation, burst pacing down to 2-to-1 capture, and either isobutyrenol or moderate dose epinephrine to see if we can get the atrial fibrillation to either initiate or sustain. Overall, we find that this process adds about an hour or so to the procedure duration. It might be substantially less if our first site of firm guidance eliminates atrial fibrillation after just a couple of minutes of ablation and we can't reinitiate it. Not a common situation, but it has occurred several times, and so we're done in about 10 or 15 minutes. With the firm portion of the procedure. But I've had it go longer than an hour as well, but roughly an hour of additional mapping for firm. With this, we find sources, either rotors or foci, in almost all cases, and these tend to be near the pulmonary veins in about a quarter of cases. This has been the impetus for doing pulmonary vein isolation first. If we're going to knock off some of these anyway with pulmonary vein isolation, let's just do it now and save the firm mapping time for anything that's outside of that area. These tend to be on the roof, and another 20% of cases, other left atrial sites. Importantly, we're seeing a lot of right atrial sites nowadays. 50, even 60% have something going on. We'll come back to this later. Ablation at this site may slow or terminate atrial fibrillation in a substantial proportion of cases. We found a lot go directly to sinus rhythms. Sometimes we can reinitiate these, but importantly, these are occurring in people with persistent atrial fibrillation, even long-standing persistent atrial fibrillation, with very good long-term outcomes in several series that have been reported. Some of those are shown here. I'm not going to go through this in any detail, but it's pretty monolithic. A large proportion of the cases are persistent or long-standing persistent, and the results are roughly similar, 70-80% freedom from atrial fibrillation anyway. Atrial tachycardias are still present in some cases. This is our own series. It's soon to be published in the Journal of the American College of Cardiology of 170 cases that I've done. There's a reasonable concordance across all of these different series that have been that I show here. These are almost all in conjunction with pulmonary vein isolation. Some of ours were firm only, and there are some series with firm only. And in some of the series that have been reported in the literature with poor outcomes, these are often rather difficult cases, the 4th or 5th procedure in an individual. That may not be the best case for any technology, but I've heard it said, this is a direct quote from some of my buddies, oh, this would be the perfect case for testing how firm does. It's the 3rd or 4th redo. Maybe that's not the best case for much of any technology. In our series here, the termination rate in 170 cases, I have them broken down by paroxysmal, persistent, or long-standing persistent. We've got about almost a 60% termination rate in the paroxysmals. I don't attach too much significance to this, but because by its very nature, paroxysmal atrial fibrillation is prone to spontaneous termination. So that doesn't mean so much, but when you have persistent or especially long-standing persistent atrial fibrillation, termination when guided by firm mapping, that means something. This is against the historical average of about 40% termination of paroxysmal atrial fibrillation during ablation, and only about 10 or 12% of persistent termination. When we've done this, this is a Kaplan-Meier curve from our series. It's soon to be published. We have very good freedom from atrial fibrillation in the paroxysmals, not terrible in the persistence and long-standing persistence. And this is going out to actuarial 1 year, about 83% freedom from atrial fibrillation in our series. Now, not everybody gets these results. Why is that? Despite our very encouraging results and those from other labs, there have been some problems. So one of these, I'm going to highlight 3 different areas. One is basket positioning and coverage. The firm map is a much easier catheter to get in a good position than the Constellation catheter, and much better coverage, but it's not perfect, and you have to work with it a little bit, especially in the left atrium. What I've found is helpful is I get my sheath very far out on the left atrium, get the basket catheter all the way to the tip of the sheath, pull back the sheath over the catheter because it's otherwise pretty much of a spear when all the splines are folded in together. Pull back, exposing about 3 electrodes, and then just push the catheter out all the way. It squishes, it compresses off to the lateral wall or out into a pulmonary vein, out into the appendage. Then I pull the sheath back and then snug it up, and pull the basket catheter up, snugging it up to the septum. Sometimes we have to give it a little twist, clockwise or counterclockwise, to get the splines to separate out nicely. Usually this suffices. If there's some areas that we know are not well covered, such as, for instance, the catheter cants a little bit forward towards the anterior wall, that's great, but we have relatively poor coverage of the posterior wall and floor. I will eliminate all the sources found on maps derived in that basket position, and then clock the catheter and sheath over, manipulate it around till we have some other areas. Maybe it's just twisting the electrode around for a little bit better distribution of the splines. A correctly sized basket will almost never go across the mitral or tricuspid valve. You can get it to do it, but it's not nearly as prone to doing that as the Constellation catheter was. And if the ablation catheter gets tangled up in the splines, it's usually a pretty simple matter to just push the splines further out, advance the basket catheter until the splines are beyond the ablation catheter, push the sheath over the basket catheter, and then pull the sheath back in. That works reasonably well. Other areas where there have been some problems with inconsistent results are in the recognition and confidence in what consists of an AF source as indicated by firm. Reading maps is not the easiest thing. I find that some people have a knack for this, and other people it's just really difficult. Some of the tools help us somewhat, and just some process helps. I played the movie through a couple of times without any of these visual aids such as wrap or spotlight. I try to focus on one corner, 1/4 of the screen. Is there something going on over there? No, there really isn't. Okay, let's look at another area, but by then the movie's halfway through, so you have to play it through a couple of times. It's only a few seconds to play the movie, so you don't waste a lot of time with that. So I play it through 2 or 3 times and say, yeah, I think there's something going on there. Then I can turn on the rotational activity profile. If what it sees agrees with what I'm seeing, then we're home free. We go ahead and act on that. I go ahead and look at another segment just to confirm that it's consistent over the entire epoch that we've recorded. If the wrap, however, suggests an area that I've not seen with my own eyes, I look at that with a very skeptical perspective, and make sure that it's consistent through that movie. Play that through a couple of times. Look at another segment just for consistency. If it still looks good, then I'll go ahead and act on it. If the wrap sees something that I just can't be convinced with, I'm not going to act on that. Spotlight also helps by shielding, kind of masking these areas where there's fibrillatory conduction that really isn't helping and is a distraction. I will again review additional segments, even those that the machine doesn't pick. For consistency, there are some software enhancements coming that will help us in that regard as well. What one individual has as a threshold for declaring that we have a rotor or a focus present might vary from what another individual sees. For instance, do you have to see 3 rotations, 4 rotations, 7 rotations? Does it have to be present through the entire segment? Is it okay to have a change in direction of the rotation? It probably is, because these can migrate out to the epicardium and come back still in the same region, but with a different direction of rotation. Certainly faster mapping has allowed us to see more sources than we did in the original series, and this has posed a problem conceptually for some individuals. How come we're seeing more than we did before? Were we missing some before, or are some of the ones that we're seeing now not really part of the action? We'll address this in a second here. The third problem that we have is, how much do you ablate? And once you've found a good basket position, once you've found a source that you're comfortable with, what area do you ablate, how much do you ablate, and how densely do you ablate? Our early experience suggested that relatively small amounts of ablation was satisfactory. We could get termination or slowing, and when you're doing proof of concept, you try to get away with as little ablation as possible. I did this in some of our early work. I've had some of those patients have recurrences, and we've reported on them as such, as failures despite initial termination. So nowadays I have a little bit more dense ablation, a slightly larger area than we had before. This is not a huge difference in what it was, but I think it has a little bit better bent towards elimination of the source and better outcomes. So the endpoint of our ablation procedure, again, now is elimination of the near field recordings in the area that we're ablating, and reassessing on remap that the source has in fact been eliminated. It's not moved around somewhere, it's just gone. then we can look for other sources. I revisit that area if we're in the same atrium to make sure that we haven't just had some edema and knocked down the signals, but they're still robust. I'll go ahead and ablate those areas again if necessary. That's not very common nowadays with irrigated ablation, but it does happen sometimes. Occasionally, our sources point us to areas that we would not like to ablate, such as the AV node or His, the phrenic nerve, the esophagus, where a pacing lead is, or very near a valve prosthesis. That's not a very common situation, but it could occur. Now, here's a couple of different patients that I did. This is one of my early patients in about 2000. This might have been the first one I did. This is a fellow who had a source on the roof of the left atrium, and we just had a couple of ablation points. The purple spot is where termination occurred, and we were just done. We couldn't reinitiate atrial fibrillation, and he's had recurrent, very sporadic episodes, not near as much as he had, but he's had some atrial fibrillation since then. So he's a failure, probably because of inadequate ablation. Nowadays, we would ablate in a much more dense area and a little bit larger area than this. And this fellow's a right atrial ablation, obviously. Here he's had another source on the septal aspect of the left atrium. This fellow's had a very good outcome with a dramatic turnaround in his course, probably because of a little bit better elimination of the source here. Now, there's still some questions about these rotors here. Why don't I see a more termination of atrial fibrillation? If the rotor is actually what's keeping the fibrillation going and we eliminate it with ablation, why doesn't it terminate? Well, there might be some other mechanisms such as multi-wavelet reentry. Quite often we'll see atrial fibrillation terminate a minute, 5 minutes, 15 minutes after we've finished ablation at a source. Well, probably the ablation had something to do with it. These happen in persistent atrial fibrillation, not just paroxysmals. So the ablation had something to do with it. Why didn't it have an effect right away? Perhaps multi-wavelet reentry is keeping things going for a little while, but is inherently unstable, and will go ahead and terminate. There may be other rotors operative that we have not been able to detect because of poor coverage or being masked by other rotors that were going on at the time. Some of our terminations, as I said, are delayed. That confuses our interpretation of exactly what effect ablation had. You can only know that for sure if you've given one RF application and you have termination, then you can be sure that that was related to it. If it's the 15th application or the third site you're going after, it's really hard to know if the termination that you're seeing right then and there was because of where you were ablating right at that moment or something that you were ablating 5, 10, 15 minutes earlier. Why doesn't atrial fibrillation termination during ablation correlate with long-term freedom from recurrent AF? We have not found that to be a good correlation. Others have not found that to be a good correlation. Some have found it. It makes sense that it should. But if you think about atrial flutter, for instance, we used to, in the early days when I was doing this, we would terminate flutter with ablation. We couldn't reinitiate it, and we'd say, okay, we're done. That's a good endpoint. And a lot of these people had recurrences because we did not eliminate the substrate. Nowadays, when we look for bidirectional conduction block, we would never stop with simple termination of atrial flutter as an endpoint. We would look for bidirectional conduction block for substrate elimination. That's what we're doing with firm guided ablation nowadays. We look for substrate elimination, have eliminated the source on remapping rather than just termination. So it's probably actually a better thing to know that you've not just stung the area with termination of fibrillation, but you've actually eliminated its ability to perpetuate in that source area. Now, are all the rotors that we see with mapping pathogenic? Do they all participate in atrial fibrillation? I don't think that's probably the case. As I said earlier, more extensive mapping has detected more rotors, yet our outcomes are really not far superior from what they were before. So I have to think that some of these are not actual players, but maybe eddy currents. Refinements in our software is probably going to help with both specificity and sensitivity in saying areas that really are responsible, consistent over a larger span of time, as opposed to just something you'll see for a few seconds at a time. So in summary, this has been a little bit of a whirlwind tour of rotor mapping and ablation. And while everybody agrees that pulmonary vein isolation is an integral part of the ablation procedure for atrial fibrillation, most of us feel that certainly in persistent atrial fibrillation, other strategies should be pursued. It's not clear exactly which one is the best. We feel strongly that rotors and focal sources have an important role in maintaining atrial fibrillation in many of these patients, certainly in persistent atrial fibrillation, but also we found it in paroxysmal atrial fibrillation. Rotor and focal mapping, mapping of foci, and ablation based on this with the endpoint of iterative elimination of all rotors and foci has been demonstrated in our experience and that of others to not only be feasible but effective in human atrial fibrillation and associated with improved outcomes over what pulmonary vein isolation alone can provide. We're looking at controlled studies, very carefully done studies, using firm mapping in conjunction with or after the fact with redo procedures and a couple of different studies to get some hard endpoints with this. Stay tuned for that. And future refinements in our technology and process should further improve our both efficiency and efficacy of using this tool. And we look for some good hard endpoints with future studies and a good discussion to follow. I appreciate your attention, and we'll do some discussion now.